for joining this symposium sponsored by JAFRON China on adsorption therapy for liver support. It is incredible this year the amount of contributions, presentations, and papers we have received on adsorption, showing that probably this type of therapy is becoming the new frontier in extracorporeal blood purification. I think that we have already seen several different options offered by sorbents, for example, with direct contact with blood and hemoadsorption in case of sepsis, acute pancreatitis, trauma, burns, other situations, including COVID-19 patients with impending cytokine release syndrome. And now we have seen also recent descriptions of how to use the so-called double plasma molecular adsorption system, DPMAS, for removal of bilirubin and so on. Today, in effect, our symposium is dedicated to adsorption therapy for liver support. And I'm pleased to have with us Dr. Raki Maiwal, who has been additional professor of hepatology and is head of liver intensive care at the Institute of Liver and Biliary Sciences, and is also a member of the European Society of Critical and Intensive Care Medicine, and has published several different papers on liver support. I think it would be interesting to hear from Professor Raki Maiwal her experience on the use of adsorption in liver support therapies. So I give the word to Raki Maiwal.
I would like to thank the organizers for giving me an opportunity to talk about adsorption therapy for liver support. So this is the spectrum of liver disease, which we see in the liver intensive care unit. So we see patients with acute or acute on chronic liver failure, decompensated patients with chronic liver disease, and they have different sets of extrahepatic organ failures, which includes either kidneys, brain, respiratory, or circulatory. So respiratory and circulatory failure is actually portends a very poor prognosis and mostly is seen in context of severe systemic inflammation or mostly infections, while kidney and brain are the organs which have a potential for reversibility. So why do we need an artificial liver support, or why we are talking about adsorption therapy? Because if you see data of this from our center, which is a rapidly developing country from India, we see here that at ILBS, we see a lot of patients with acute liver failure, and our admissions were around 415. However, only 14.6% of these patients could undergo live donor liver transplant. So transplant is a scarce resource, and most of the times progression of organ failures, non-availability of a suitable donor, financial issues, and collective negative decisions portend a role of bridging therapy, which can bridge these patients to either a liver transplant or to spontaneous liver regeneration. So what I'll be discussing in the next 15 to 20 minutes is about the rationale. Why do we need an artificial liver support or adsorption therapy, the timing and intensity of therapy, the choice of patients, and the different modalities that exist in the current era. Now, when we look at the goals of liver support therapy in context of liver failure, so we are looking at a bridging therapy, and we're also looking as a therapy which can rescue refractory organ failures, particularly in context of severe systemic infection. Now, the main indications for artificial liver support include management of cerebral edema, systemic inflammation, and cytokine release syndrome, which is very common in these patients, as an adjunctive therapy, as I already mentioned, about refractoriness of organ dysfunction and failures, and as a rescue therapy, and also to achieve the goals of immune homeostasis, improve the microcirculation and hemodynamics, lessen the chances of multi-organ dysfunction, and improve the overall outcomes. Now, this is an important cartoon just to represent patients with acute and chronic liver failure, where they're predisposed and they have a background chronic liver disease, compromised hepatic reserve, which varies from patient to patient, and gut dysbiosis, which predisposes these patients to endogenous endotoxemia, the insult by damage-associated and pathogen-associated molecular pattern or endotoxin. And there is a subsequent acute insult in the form of viral infection, drugs, alcohol, and other unknown or known precipitant. And the response, the basic response, is the release of these pro-inflammatory cytokines, a decrease in the anti-inflammatory cytokines, and mark impaired liver regeneration, systemic inflammation, and a state of acute portal hypertension. And mostly there is organ involvement, where we need a reversible strategy which can be used for targeting the therapeutic or ameliorating the cytokines, DAMs, endotoxin, and bile acid mediated damage to the different organs and the immune system. So the timing is important because we know that these patients very quickly from a state of systemic inflammatory response syndrome progress to a compensatory anti-inflammatory response syndrome. And this is where, if you're timing your therapies quite late, your therapies may not provide you the results which you need. And most of the times these patients are already in the dying state and culminate to death, infections, and progression of organ failure. However, if you time your therapy in the early phase, so timing early in the disease course and giving a response-guided approach can result in not only bridging these patients in case there is no spontaneous recovery, but also we can achieve spontaneous survival. So we have proposed from APASL the concept of golden window, which we say that in acute and chronic liver failure is the first 1 to 2 weeks where you have to time these artificial liver support therapies. And this is in context of plasma exchange. So when we see patients with liver failure, we have toxic substances which accumulate in these patients, which includes the bilirubin, bile acids, the ammonia, the protein breakdown products, lactate, glutamine, mediators of oxidative stress, free fatty acids, and other inflammatory cytokines. And all these are responsible for the dysfunction of various organs and failure of native liver regeneration. So we really need an adsorption therapy which can remove most or a large amount of these accumulated toxins. So I already talked about damage-associated molecular patterns, and we know about the concept of sterile inflammation, and these damage-associated molecular patterns can be cytosol-driven. They can arise from the plasma membrane, endoplasmic reticulum, or mitochondrial DNA, and these accumulate and cause end-organ dysfunction. And similarly, as I already talked about in context of infections, and we know that in patients with acute liver failure, 47% of these patients have the damage to the kidneys because of the DAMs or the PAMs. And therefore, there is a need for amelioration of these cytokines so that this cytokine impairment can be, these patients can be salvaged from the effect of these harmful cytokines where they can culminate to fulminant septic shock, refractory organ failures. So again, here, I just wanted to highlight that it is not just the pro-inflammatory cytokines, but it is also how this endotoxin impairs the innate immune system and the function of the monocytes. So it has been seen that with the patients progressing to compensatory anti-inflammatory response syndrome, there is also a defect in the monocyte phenotype, and these monocytes become actually non-functional with a decrease in the HLA-DR expression, and therefore these patients are unable to clear the bacterial infection. Now, another major problem when we see and when we manage patients with liver failure is the capillary leak syndrome, and this is which contributes to these patients having extremity edema. These patients have third spacing with a lot of pleural effusions, non-cardiogenic pulmonary edema. They have gastric and intestinal edema, as I talked about, ascites as a component of not only acute portal hypertension, but also this capillary leak. And they have muscle edema. And this all results in hypertension. There is acute kidney injury because of the damage mediated molecular patterns and cytokine mediated, but also to the ischemia contributed by these cytokines, which cause a decrease in the intravascular compartment fluid pressure. So now when I talk about AKI, this is an important organ, and kidneys become very, very important in patients with acute and chronic liver failure. And this was an early paper from our group where we clearly showed that acute and chronic liver failure patients, when they were matched with respect to the degree of bilirubin above 5 and INR above 1.5, we can see here that there was a distinct difference between patients with acute decompensation and patients with acute on chronic liver failure who were more severely jaundiced. They had higher scores of inflammation. We can see here ferritin and the leukocyte count, the MEL scores were higher in these patients. And therefore, these patients have higher degree of systemic inflammation-driven organ dysfunction. And in context of kidneys, because management of kidneys improves the prognosis of patients with acute on chronic liver failure, we showed again in this paper that these patients have a very high incidence of structural kidney damage, which contributes to a higher progression and need of dialysis as compared to patients with decompensated cirrhosis. And similar data from another Chinese colleague in context of HBV-related patients with acute and chronic liver failure as compared to decompensated cirrhosis and other etiologies of chronic hepatitis C, chronic hepatitis B, and patients who were decompensated without major organ failures. We can see here that a lot of biomarkers here, urine NGAL, urine liver fatty acid binding protein, the urinary KIM1, the urine cystatin C, and urine IL-18 all were markedly elevated in patients with acute and chronic liver failure due to hepatitis B as compared to other etiologies. So therefore, this clearly suggests that kidney dysfunction in patients with acute and chronic liver failure is very, very unique and is different from other etiologies. Now, what is more common and what makes distinction of this kidney damage in patients with ACLF? So I showed you data that these patients have higher bilirubin, and this bilirubin causes mitochondrial dysfunction. So there is oxidative decrease in the oxidative phosphorylation. There is a capillary leak secondary to this mitochondrial failure. And what we have shown in a large study of postmortem kidney biopsies from our center, that coulommic nephrosis was seen in 72% of patients with ACLF, as against just 27% of the patients with decompensated cirrhosis. And this again was related to high bilirubin levels in these patients. Now, in the mice model, and this was a work which was done by Fickett and colleagues, where they clearly showed that in the bile duct ligated animal model of acute and chronic liver failure, the damage to the renal tubules was mediated by the presence of aquaporin 2 positive cells in the epithelial cells of the transitional or the leaky collecting ducts. And this tubular cell injury and cast formation was causing an increased pressure in the tubular part of the nephron, causing tubular interstitial nephritis. So actually what happens in this coulommic nephrosis is there is toxicity due to not only bilirubin, but toxic bile acids, there is systemic inflammation, and these patients usually have tubular dysfunction. They are non-oliguric and they have hyperuricemia and hypokalemia. Now, I'll show you some data which is very exciting and which we'll be presenting this year in the American Association of the Study of Liver Disease meeting. And these are the urine microscopy pictures of patients of ACLF. This is the bland microscopy. We can see here clear distinction of patient with hepatorenal syndrome. This is a patient with, again, volume non-responsive AKI, which was not HRS, but it had bile cast. Suggestive of coulommic nephrosis. And this is the urine microscopy of a patient with ACLF who had acute tubular necrosis. So clear distinction between different phenotypes, and this data we showed here, and this is the patients with no AKI, and you can see here that there is a clear distinction of elevated bile acid levels in coulommic nephrosis as against ATN and HRS AKI. And these patients we showed here with the expression of mitochondrial genes. There was a suppression of the mitochondrial genes in patients with ATN as compared to coulommic nephrosis, again showing a higher potential of reversibility. These are the renal histology images, and we can see here that patients with ATN had a higher expression of tunnel positive cells in the renal tubules. There was a higher expression of hypoxia inducible factor, again indicating hypoxic mediated damage in ATN, while SIRT1 expression on immunohistochemistry was clearly upregulated in patients with coulommic nephrosis. When we looked at these around 17 urinary biomarkers in this set of patients, we found that all the biomarkers of tubular injury were markedly upregulated in ATN as compared to coulommic nephrosis, HRS, AKI, and non-AKI group. However, when we look at the repair biomarkers, it is a very interesting interesting part, we see here that coulimic nephrosis patients had a higher markers of repair, as was HRS and no AKI, as compared to ATN. So there's a clear distinction between the 4 different phenotypes of AKI in patients with ACLF. Now, systemic inflammation also we studied in this, and this data we'll be presenting, and this has been accepted as a poster of distinction in this year's ASLD. And we can see here in the heat map that there's a clear distinction in the pro-inflammatory cytokines in patients with ATN compared to coulimic nephrosis. And this is again data from a group which we published in Liver International of plasma exchange. And what we showed here was that in patients with ACLF who underwent plasma exchange, we can see here that there was a suppression of all the pro-inflammatory cytokines, but it is not that when you do plasma exchange to patients with ACLF, everybody responds. Despite that, everybody has a decrease in the pro-inflammatory and the increase in the anti-inflammatory cytokines. So what happens is that in the group, we divided these patients into responders who had responded to plasma exchange and had a transplant-free survival, versus the patients who were non-responders and died despite plasma exchange. You can see here that the HMGB1 levels were markedly higher at baseline itself in the non-responders, even though they decreased, but they remained elevated. IL-1 receptor antagonist levels were higher in responder. And another very important part which we noted here was that the monocyte function, as I already mentioned, did not improve in non-responders while it improved in the responder. And so was the mitochondrial oxidative burst capacity, which improved in the responder group as against the non-responder. And this is the data of plasma exchange, which in context of coulimic nephrosis, again, to show here that there is a clear distinction of patients pre and post. There is a reduction in all the pro-inflammatory cytokines, which I've already shown had contributed to coulimic organ dysfunction. And this, what does it result in? This results in a superior transplant-free survival and decrease in liver failure-related death. And we showed in this paper from the ARC, which comprised data from a multicentric database, that these patients have lower risk of liver failure-related death, and this was much more superior to the standard medical treatment and patients who underwent liver dialysis. Now, I'll show you some another data from the intensive care unit, again, classifying patients who underwent continuous renal replacement therapy into patients who responded or who had a spontaneous recovery of renal functions, as well as survival, as compared to patients who died while on CRRT. So we can see here that most of these patients were sicker, but patients who were dialysis responders had received dialysis when they had less severe liver disease. And we can see here these patients had lower MEL scores. The SOFA scores were also low, and majority of these patients had coulimic nephrosis, as against the non-responder group, where majority of these patients had acute tubular necrosis. And again, if you see here, the improvement in hemodynamics, the INR values, and most of these patients also underwent plasma exchange. Ammonia levels showed a reduction. The lactate levels showed a reduction in responder group, but not in the non-responder. And so was the decrease in the leukocyte count. Now, what about the coagulation? And this is a challenge when we do CRRT in patients with acute on chronic liver failure. These patients who were responders, they showed rather an improvement in coagulation, and there was no bleeding. However, in non-responder, there was a worsening of coagulation, as can be seen here by the Rotem parameters. And 90% of non-responders had bleeding events requiring discontinuation of CRRT. Now, very quickly, we'll discuss about acute liver failure. This is a different group of patients, and the challenge in acute liver failure is not only managing the systemic inflammation, but also the cerebral edema. And this is governed by not only the damage and the pathogen-associated molecular pattern and the pro-inflammatory cytokines, but also by the ammonia levels and the cerebral perfusion pressure. So there is both cytotoxic and vasogenic edema, and therefore we need a therapy which can improve all these components, maintaining the hemodynamics and improving cerebral edema. And this is again data for plasma exchange, where we showed that plasma exchange was able to reduce all the pro-inflammatory cytokines. It improved the anti-inflammatory cytokines and caused reduction in the IL-10 levels as against the standard medical therapy here represented by the black bars, and the blue bars represent the plasma exchange treated group. However, we can see here that plasma exchange, why is it not still established? Because repeated sessions, and in this study, we showed that there was a decrease in the levels of growth factors. Now, whether this is good or bad for the patients, we really do not know, and therefore we need further studies to look at the effect of removing these pro-inflammatory cytokines and the damage-associated molecular patterns. Similarly, if you see here, patients who underwent plasma exchange as compared to standard medical treatment had a significant reduction in all the damage-associated molecular patterns. We can see here there was a reduction in the endotoxin levels. And when you combine plasma exchange with CRRT, we can see here the group which just went on CRRT along with standard medical treatment versus a group which underwent plasma exchange with CRRT. We can see here that there was clearly a higher reduction in lactate, ammonia levels, and improvement in mean arterial pressure when patients underwent a combination therapy as against patients who underwent CRRT alone. So what should be the modality? So should we be doing an either or one or the other of these therapies, choosing a continuous renal replacement, a standard volume plasma exchange, a molecular adsorbent recirculation system, or a liver dialysis, or should we be going with a combination therapy? And when we talk about combination, now here we'll be focusing on just using a standalone cytokine hemoadsorption or DP mass therapy, or combining it with plasma exchange or CRRT. So adsorption therapy is basically been started from times in context of patients with sepsis. So very sick patients, because here you have different type of hemoadsorption cartridges that are available, the Turamixin, Cytosorb, Oxyrus, the LPS adsorber, and the HA330. So all these adsorbers have one or the different effect on the cytokines. So Turamixin can remove the endotoxin. Cytosorb does not remove endotoxin, but it can remove all the pro-inflammatory cytokines, DAMs, bilirubin, bile acids, and particularly this is good for patients who have septic shock in context of liver dysfunction. Oxyrus can remove both the endotoxin and cytokine levels, and HE330 can again improve the cytokines and the complement system. And this is the data from the Euphrates trial. This was a negative study done in context of patients with septic shock, and those patients there, they did an endotoxin activity assay for all these patients, and they showed that there was a 10% reduction in the mortality in this set of patients where the endotoxin levels were very high. And this is the data from our ICU where we did the endotoxin levels for all these patients of cirrhosis at day 1 and day 3. And we can see here that as compared to procalcitonin, endotoxin activity assay had a better area under the ROC for prediction of septic shock. So it is important that we should be measuring endotoxin, and maybe the clearance of endotoxin by different adsorbers could be very, very helpful strategy in context of severe patients with septic shock, and especially in context of multi-drug resistant infection. And this is a study which was an in vitro study comparing the 3 different hemoperfusion cartridges, the Cytosorb, Oxyrus, and Turamixin, where they looked at the LPS removal rate, and they showed that Turamixin had the highest and the fastest efficacy in removing the endotoxin, followed by Oxyrus, while Cytosorb could not remove the endotoxin. However, when we looked at the cytokine levels, and these are all the pro-inflammatory cytokines that were studied, we can see here that patients had removal of pro and anti-inflammatory cytokines, which was highest for Cytosorb, followed by Oxyrus, but Turamixin was not able to remove. So different hemoadsorption therapies we should be knowing when we're looking at patients with acute liver failure, acute and chronic liver failure. What are we planning to target? Are we planning to remove the bilirubin? Are we planning to remove the bile acids, the SIRS response? So therefore, or we are using these hemoadsorption cartridges in context of infection. So we have to choose our therapy most appropriately based on the requirement. And this is the data of our cytokine hemoadsorption from JAFRON. And this is the HA330, which we used in our ICU patient in context of refractory shock. These patients had ARDS. They were majority of these patients required CRRT, and this was an extremely sick group of patients where we found that initial response pre and post therapy was there and was remarkable in context of improvement in lactate, the vasopressor dosages, and the PF ratios in these patients. And we can see here there was a significant reduction, and also there was an improvement in the bilirubin. In context of sepsis-induced cholestasis, the procal levels and the ammonia levels all showed reduction in these patients pre and post therapy. So we did here, most of the patients underwent just one session, two sessions were done in 5% of these patients, and one patient required 4 sessions. And the therapy was initiated, we initiated these therapies very early on, and 47% of these included patients were acute and chronic liver failure. And when we looked at all the pro-inflammatory cytokines here in this, we can see here that these the hemadsorption was able to remove the IL-6, and there was a highest percentage clearance of IL-6 and IL-10 after the therapy in these patients. Now, in context of liver failure also, I'll show you some data, and this data was presented last year, and this trial was funded by JAFRON, wherein we conducted a randomized controlled trial in context of patients with acute and chronic liver failure. And we were planning to study the role of heme adsorption cartridges, which could enable removal of bile acids as compared to standard medical therapy and plasma exchange. Our primary endpoint and secondary endpoint did not show difference. However, we were able to show a marked reduction in bilirubin and bile acids with both these therapies, which also correlated, the degree of reduction correlated with improvement in survival. This is the data from the University College of London from Rajiv Jalan and his group, where they, in a pig model of acute liver failure, they have developed a cartridge which has a high cutoff filter for extraction of albumin, endotoxin, and performs the hemofiltration. And in the pig model, they developed this for removal, for ameliorating the circulatory failure and acute lung injury by causing irreversible a decrease in the circulating irreversibly HNA2 fraction of albumin and endotoxin and TLR4. And this is what they have called as a DIALYSIS, and this is being studied currently in a multicenter randomized controlled trial in context of patients with acute and chronic liver failure. And in context of ACLF, there are some published data from the Chinese colleagues where they showed that DPMAS, which combines the BS330 with HA3302. And they showed that TPE was more effective than DPMAS in clearing, because here they showed that the IL-6 levels were markedly decreased in patients with TPE group as against the DPMAS group. And so was the HSCRP levels. Even though the reduction was better, these patients who had influenced the parameters of systemic inflammation were equally cleared by DPMAS and TPE, and these therapies were equally effective. And this is a study where they actually studied a combination of this DPMAS along with half volume plasma exchange. And they showed that in patients of acute and chronic liver failure, the therapy which combined the DPMAS was actually good for patients who were sicker, and those were in the intermediate and late stages. This was based on the prothrombin time categorization. And therefore, in the later group, in the early stage, it was comparable, like we also showed you data. But in the later group, the intermediate or the late stage of ACLF, these patients had a higher mortality, or who were just treated with plasma exchange as against the combination therapy. So I would like to summarize my talk by saying that the current understanding of acute and chronic liver failure is driven by systemic inflammation, the toxicity due to bile acids, and maybe infection is driven by these components. Therefore, the adsorption therapy looks like an exciting option to support the failing liver until spontaneous recovery or liver transplant by removing these cytokines, which are very toxic, the toxic bile acids, the ammonia levels, and can ameliorate the organ dysfunction. It can effectively salvage the patients who have sepsis-associated refractory vasoplegia, a cytokine release syndrome, or ARDS. And the choice of patient depends on the goals and basically understanding of the safety and efficacy. And really, we need more data in well-controlled randomized controlled trials for routine recommendation of these therapies. And I would like to thank you for your very kind attention.
Thank you, Dr. Raki Maiwell, for your presentation. It is now the turn of Dr. Tiago Reis. Tiago is head of nephrology and kidney transplantation at the Clínica de Doenças Renais de Brasília in Brazil. He is researched at the Laboratory of Molecular Pharmacology at the University of Brasilia, and has been affiliated and is still with the International Renal Research Institute of Vicenza, Italy, and he is member of the Brazilian Society of Nephrology. So, Tiago, welcome back to Vicenza, although in a virtual form, and please give us your knowledge and experience on the use of adsorption for liver support. Thank you.
Thank you, Professor, for the invitation, and thank you, JAFRON, for sponsoring this activity. I will share my screen. So I will try to cover briefly in 40 minutes all the aspects of adsorption therapy for liver support. These are my conflict of interests. And first, covering hyperammonemia. So there is this phenomenon that occurs in the brain, in the astrocytes, when we have high concentrations of ammonia. It gets together with glutamate, making glutamine, which has a osmotic property and causes an inflow of fluid from the interstitial space towards the astrocyte, creating brain edema. So this is a serious threatening condition. And when usually ammonia is above 200 micromoles per liter, we advise to start CRRT irrespective of AKI, first with a high flow phase, an effluent of 90 mL kilograms per hour to keep ammonia below 100, and then a maintenance phase with an effluent of around 35 mL kilogram per hour. This is the statement of the last guidelines for liver failure. So CRRT should always be undertaken in critically ill patients with acute liver failure as opposed to intermittent hemodialysis. So the preferred modality for those patients is CRRT. And this is an example in the machine. So here is the dialysate flow, 5,000 miles per hour, replacement only 300 miles per hour, and an effluent, in this case here, was 79 mL per kilogram per hour. So diffusive clearance mainly. This is the representation in the machine. So you can see the pump from a dialysate and the effluent spinning fast with those that high dose. Hyperbilirubinemia and biliary acids. So this slide shows that biliary acids, they have a path through a transmembrane receptor which can activate a pro-apoptotic path. So biliary acids, they can be toxic to the liver itself when they accumulate, and of course to renal tubule cells, causing biliary acid nephropathy. And in those patients, there was this debate if we could use citrate anticoagulation, and data shows that it's safe. So in this analysis, including 1,000 patients, those that had normal lactate, less than 1% had signs of citrate accumulation. Those with elevated lactate, only 2% had signs of accumulation, and those with persistent elevated lactate, only 6% had citrate accumulation. So it's a rare phenomenon. It mainly occurs in patients with severe sustained hyperlactatemia, but not in patients with liver failure. So tests for liver failure, they are not predictable. They are not good predictors for citrate accumulation. So we can claim that citrate is safe in liver failure. About the liver support systems. So first with hemoperfusion, we have these two cartridges, BS330 and HA3302, and they can remove via adsorption this range of molecules in this range of molecular weight. And this is the representation of the beads, which are porous beads, and inside those porous that we have the phenomenon of adsorption. So bilirubins and bile acids, they get trapped, and the pore size determines the selective range of each of those different cartridges. So the pore size here is of paramount importance. The electron scan microscopy of those tiny beads. So this is the representation of the bead itself, and this is the surface of it with those pores. And now the representation of the extracorporeal circuit for DP mass. So it's a therapy that takes like 2 to 3 hours, 2 to 3 times a week. The blood flow in the circuit is from 100 to 150 mL per minute. So the blood goes in this way, passes through the pump, gets the citrate coming here in this part, and then goes through a plasma filter that directs 30% of the plasma to a parallel limb of the circuit. Then we have another pump for the plasma, and finally passing through BS330 and then HA330, finally returning here in the deaeration chamber, going back to the patient. So this is a representation of DP mass here in the circuit in the Diapact machine. We can also apply both therapies, DP mass and CRRT, in parallel at the same time. So we can place a Y connector in the catheter, in the arterial line of the catheter, and then simultaneously 120 mL per minute of blood going through the CRRT circuit, let's say in a patient with hyperammonemia, and in parallel 120 mL per minute going through the DPMA circuit. And then finally here they return to the patient with another Y port. Another treatment is the PAP, plasma adsorption perfusion, which is an albumin free. You don't need to replace albumin to the patient. The catheter here, the blood passes through the blood pump, and then a plasma filter that directs 30% of plasma through a cartridge, this cartridge here, and then they merge with the rest of the blood in the bubble trap. So here in the left is the plasma filter, in the middle, the cartridge. Here's the machine, the warmer for the plasma. Here's a representation of the blood flow, 150 mL per minute. And here's the whole circuit. So the plasma, filter, and the cartridge. This is a treatment. And in the left, we have the blood pump. And here is the pump for the plasma after it passes through the plasma filter before going to the cartridge. Another treatment for liver support is MARS, that stands for Molecular Adsorption Recirculating System. So MARS has 4 components. So here is the high flux filter in which the blood goes from up to down here and inside capillary fibers. And in the dialysate space, we have a solution of albumin. This albumin is not now, it's dirty, let's say like this, and passes through a pump and then goes into a low flux dialyzer. But in this case, the albumin goes inside the fiber, and the outside is a normal dialysate solution. This albumin passes through a activate charcoal cartridge and then a ion exchange cartridge. So this is the activate charcoal, this is the ion exchanger, and then it's let's say purified to go again in this loop. So this is a representation of the circuit. And one downside of this therapy is the need for albumin, 600 mL of albumin. Another treatment is the SPAD, that stands for single pass albumin dialysis. In this case, it's a normal CRT machine, normal CRT treatment. However, here that I'm pointing down in the green scale, we have a solution of 3% albumin instead of a normal dialysate. Then the representation of the extracorporeal circuit, imagine if the blood is coming from the left to the right. So the blood goes in this direction, gets citrate, passes through the blood pump, and then here is the dialyzer. The albumin 3% solution as a dialysate solution goes in countercurrent with the blood, and then the blood passes through the warmer, bubble trap, gets calcium compensation, and returns to the patient. A recent paper published in Blood Purification compared patients that were submitted to SPAD and then cross over to MARS, and the results showed that the reduction of bilirubin pre and post session were equivalent both in the group SPAD and in MARS. So we don't have clinical outcomes comparing patients submitted to both modalities, but at least for this surrogate marker, so bilirubin, those treatments are equivalent. And one advantage of SPAD is that you can apply it in any service when you just need to have a CRT machine So it's more widely available, let's say like that. Another therapy for patients with liver failure is plasmapheresis. So this was the statement in the guidelines. Plasmapheresis has been shown to improve transplant-free survival in patients with acute liver failure. This was based on the results of this trial conducted from 1998 to 2010 with 5 centers, 182 individuals with liver failure and at least grade 2 encephalopathy. They were randomized to receive standard care or standard care plus high volume plasmapheresis, meaning to exchange 12 liters of plasma in 3 consecutive days. It was demonstrated that, so in this figure, in the x-axis, we have the time after the treatment was initiated, and here the cumulative survival. So in patients that were submitted in the end to liver transplant, there was no difference if they performed or not previously plasmapheresis. However, in those patients that were not submitted to liver transplant, those here that had treatment with high volume plasmapheresis had a better outcome when compared to patients here, the downline, that were not submitted to, that did not carry plasmapheresis. So this is briefly the representation of the circuit. Bloods get citrate, blood pump, and then here is the plasma filter, not a dialyzer anymore. And then before the blood returns to the patient, we have a replacement solution. In this case, for liver failure patients, we replace here fresh frozen plasma. This trial in China compared DP mass versus plasmapheresis in patients with hepatitis B and acute liver failure. And as a secondary outcome, so exploratory findings, the sample size was not calculated to these outcomes. However, there were no difference in mortality comparing patients that were submitted to plasmapheresis, 33 versus 14 to DP mass. And finally, this paper from Italy compared 3 modalities of liver support. So PAP, plasma adsorption perfusion, plasmapheresis, and MARS. It was a retrospective analysis, so 66 patients that performed PAP, 15 plasma exchange, and 14 MARS. And regarding the reduction in bilirubin before and after the treatment, we can see that for PAP it was around 30%, PAX 27%, and MARS 26%. So they were equivalent. There were no statistical difference in the reduction of bilirubin comparing these 3 modalities. And the authors conclude that based on costs and duration of treatment, we suggest that PAP could be considered as a first-line approach for patients with hyperbilirubinemia. So I thank you for your attention. Let's move forward. Thank you.
So thank you very much, Tiago, for your very nice overview. I have an immediate question to ask you, just to make people understanding. What is the difference between PAP and DP mass, except that in one case you have 1 cartridge and in the other you have 2 cartridges? What is the mechanism and the difference?
Well, adding an additional cartridge to the circuit, in the case that HA330, amplifies your magnitude of removal, because now with this other cartridge, another range of molecules can be removed, mainly inflammatory molecules that are involved in patients with acute decompensated liver failure. So this would be the additional to your already capacity to remove bilirubin and bile acids.
Why these cartridges cannot be placed in direct contact with blood?
Because this would increase the risk for clotting. So an intelligent solution was to use only plasma and avoid the use of albumin. That would be also a solution. So this is an intelligent way to overcome the problem of clotting.
Okay, so now what would be the ideal candidate for you to undergo this type of liver support therapy?
Well, as we have in the guidelines, if we if we detect that the patient has higher concentrations of ammonia, certainly CRRT, and to modulate the inflammatory response, applying a cartridge such as H8330, and to aiming to remove bilirubin and bile acids, also the BS330. So I think an ideal treatment could be doing in parallel, so CRRT with DP mass.
We have done in our laboratory a series of experiments showing that the capacity of the cartridge to remove bilirubin is very high, and it can continue up to 12 hours of usage. What is your recommended timing of application and duration of application?
Well, based on data from the AirCold trial that was performed in Italy, it was a different cartridge, but they've demonstrated that after 6 hours, the concentrations of bilirubin pre and post cartridge were the same. So demonstrating that the cartridge was already saturated. So I would say something between 6 to 12 hours.
It depends, of course, on the concentration of the solute, because the isotherm that governs saturation of the cartridge depends on the flow you're using and depends on the initial concentration. The higher is the concentration, the sooner the saturation may occur. Now, one question, what blood flow would you advise and what plasma flow would you advise, and what is the amount of plasma that in your opinion should be circulated?
Well, so blood flow, I would say 150 mLs per minute. So in this case, we have around 120 mLs per minute of plasma passing through the plasma filter, and then we direct 30 mLs per minute. That would give us a filtration fraction of 30%, which is okay not to avoid clotting if we go further, let's say 40% of filtration fraction. So a blood flow of 150, a plasma in the parallel limb of 30 mLs per minute, and treating around 5 liters of blood that usually of plasma that usually equivalent to 1.5 volemia of plasma of those patients. And in these settings, the therapy, the session would take like 3 to 4 hours, I'd say.
Do you have a preferred anticoagulant in this case?
Yes, I am a completely fan of citrate. So I think it's safe. We have already data for that. And so I would advise using 4% sodium citrate as an anticoagulant.
But isn't that true that if you have a liver failure, citrate cannot be easily converted and you have a risk of accumulation?
Yes, there is this risk, but as citrate is also metabolized in the musculature, also in the kidneys themselves. So we can measure, and we are dealing with short sessions of 6 to 12 hours. We would expect citrate accumulation in CRT for, let's say, 48 hours, 72 hours, and we can measure those parameters every 6 hours. So I think we can predict if citrate will accumulate or not.
One last question. What would be your ideal candidate for endpoints in case of a randomized study?
So as endpoints, I would say 3-day ventilatory free days. I would say days without drugs in the ICU, without vasopressors, days without sedation, and especially in liver failure patients, neurological outcomes. So days without sedation, sequelae after patients are outside the hospital. So I would use this as outcomes.
Okay, I think we have come to the conclusion of this sponsored symposium. I would like to thank Dr. Araki for presenting her experience, Dr. Tiago for the nice overview and the nice question and answer interaction. So let's go back to the scientific program of the 39th Vicenza course on AKI and CRRT.